Dear friends, today we are going to discuss now the C3 glomerulopathy. When the glomerulonephritis is associated with the dysregulation of the complement pathway, so this is referred as a C3 glomerulopathy. Now we define the C3 glomerulopathy on the basis of the immunofluorescence. There is dominant C3 on immunofluorescence. So this is the glomerulonephritis with dysregulation of the complement pathway, and it is basically defined on the basis of the C3 presence of the C3 or C3 dominance on the immunofluorescence. When we do the immunofluorescence, the C3 deposition are mainly found. This glomerulonephritis this dominant glomerulonephritis may be of two types. Number one is the C3 glomerulopathy, and number two is the post-infectious glomerulonephritis. If we talk about the C3 glomerulopathy, the C3 glomerulopathy may be further subdivided or may present as a dense deposit disease or may present as a C3 glomerulonephritis. So, if we talk about the glomerulonephritis with dominant C3 on IF or immunofluorescence, may be of two types, which we call the C3 glomerulopathy and may be found in the post-infectious glomerulonephritis. Now, this C3 glomerulopathy may present as a dense deposit disease or may present as a C3 glomerulonephritis. And this C3 glomerulopathy may also present in future as a non-resolving post-infectious glomerulonephritis. Non-resolving post-infectious glomerulonephritis. Now we talk about the pathogenesis. Basically, the C3 glomerulopathy is the hyperactivity of the alternative complement pathway. This is the hyperactivity of the alternative complement pathway, and this hyperactivity of the alternating complement pathway mainly associated with the auto antibodies, which we call C3 nephritic factor, Now, there may be other abnormalities like genetic mutations related to the complement regulatory proteins. The complement regulatory proteins, if there is genetic mutation in the complementary regulatory proteins, so they may present as a C3 glomerulopathy, and this C3 glomerulopathy may be triggered by the infection. C3 glomerulopathy may be triggered by the infection. So this is about the pathogenesis, brief about the pathogenesis. Now, how does it work? Mechanism of the complement pathway dysregulation. How complement pathway is dysregulated, we are going to define. Number one is the if we talk about this dysregulation, so there may be the genetic mutations. Number one, there may be the genetic mutation, and these genetic mutations may be related to complement factor H, complement factor I, complement factor B, MCP, and complement factor H related protein, complement factor HR5. So complement factor H related protein 5. These genetic mutations may be related to. Number two, this is the number one. Number two, the C3 nephritic factor. Basically, C3 nephritic factor is the auto antibody which stabilizes the C3BB, C3 small b and capital B small b. So C3BB, this is the auto antibody which stabilizes the C3BB. Now C4 nephritic factor. C4 nephritic factor is basically which stabilizes the CZ4B2A and is responsible for the dysregulation of this complement pathway. Like this, the C5 nephritic factor, and this is the auto antibody which stabilizes the C5 convertase. Beside this, there may be the complement factor H auto antibodies, and there may be the complementary factor B auto antibodies. Besides this, there may be some monoclonal gammopathy, and monoclonal gammopathy may trigger the dysregulation of the complement pathway. So this is about how the complement pathway is dysregulated in this kind of disease, which we call the C3 glomerulopathy. This is the mechanism how the alternative complement pathway is dysregulated. So now we are going to discuss the pathology of the C3 glomerulopathy. If we talk about the pathology and if we see the light microscopy, so in light microscopy what we see, there are some MPGN, endocapillary MPGN type picture. So there is endocapillary MPGN type picture, there is mesengoproliferative glomerulonephritis like picture. In light microscopy we usually found the endocapillary MPGN like picture, and there is mesengocapillary glomerulonephritis like picture in light microscopy. But if we see the immunofluorescence, in immunofluorescence basically there is the dominance of the C3. If we see the immunofluorescence, this is to remember, this is the most important to remember, that if we do the immunofluorescence, there is the deposition of the C3. So C3 dominance will be there in C3 glomerulopathy. If we go for the electron microscopy, so in electron microscopy what happens, if there are intramembranous electron dense deposits, if there are intramembranous electron dense deposits, so this intramembranous electron dense deposit, if these dense deposits are basically positive, then it may be the dense deposit disease. And if this intramembranous dense deposits or electron dense deposits are absent, then it may be the C3 glomerulonephritis or C3 glomerulopathy. So this is the pathology. These are the findings of the light microscope, immunofluorescence, and electron microscopy. Now we come to the clinical feature. If we talk about the clinical feature, basically the patient may present from nephrotic range proteinuria to the subnephrotic range proteinuria. The patient may present with the hematuria, synpharyngitic hematuria may present, and the patient may present with the synpharyngitic hematuria. The patient may present with the hypertension, the patient may present with the edema, the patient may present, if we see the retina, there may be the drusen molecules or drusen deposits, which are the which are the complements, which are the deposits in the retina, and we call it drusen molecules or drusen deposits. So this is the basically clinical feature the patient may present with this disease. Now what the workup, basically if we do the workup, so predominantly there will be the low C3, but the C4 will be the normal. This is the characteristic. The C3 will be the low and the C4 will be the normal, and there will be C3 nephritic factor. If we do the complement pathway abnormalities, if we see the complement pathway abnormalities, so there may be the C3 nephritic factor H antibody. We can do the factor B level, we can do the factor I level, we can do the soluble membrane attack complex, etc. Besides this, we can go for the monoclonal gammopathy screening. We can go and we can do the serum immunofixation electrophoresis, and we can do the free light chains, etc. to check whether it is related to the monoclonal gammopathy. Now, if we talk about the treatment about this disease, so the treatment, there is very little role of the immunosuppression. There is a very little role of the immunosuppression. There is no. This is the controversial whether to give immunosuppression or not. Next, there is some role of the eculizumab. Eculizumab is basically have some role, and there is also having some role of the FFPs. So we can give the FFPs. So besides this, if we talk about the prognosis, more than 50% of the patients who present with the C3 glomerulonephritis or glomerulopathy may progress to end stage renal disease. So this is about the prognosis. So this completes in brief about the C3 glomerulopathy or C3 glomerulonephritis.